Let me introduce you to the MSD of Neuro Intervention in India, the Dhoni of Neurointervention, my good friend, Dr. Vikram Huded. Congratulations for that as the best neurointerventionist in India. I think that's amazing stuff. What is a stroke-ready hospital?
Yeah, stroke-ready hospital, usually what happens? So the fastest we have done from door to needle time is 13 minutes.
Whoa. So somebody had 100 strokes or more than that. We get scared with one stroke, you will die, you will survive, disability. How is this guy walking around with 100 strokes? What's going on here?
Brain stroke can happen from day one child till 100 years. So anyone can have brain stroke.
Okay.
So brain stroke as definition is the blockage to the blood flow to the brain, retina and the spinal cord. So anything...
Oh, retina is also part of brain stroke.
Yeah. Whenever I go for saloon, I educate them. Don't touch my neck. The doctor who had dementia, he started practicing.
Amazing.
Yeah.
Inspiration, like you said, was very important because I think the current generation, what they lack is inspiration. They have too much of information.
And the good news is that it is a treatable condition and we can prevent it also.
That's the message that we want to give, that don't give up. See, a lot of people, I also stroke targets, they think that their life is gone.
ജ്ഞാനാനന്ദമയം ദേവം നിർമ്മലസ്ഫടികാകൃതിം ആധാരം സർവവിദ്യാനാം ഹയഗ്രീവം ഉപാസ്മഹേ ആധാരം സർവവിദ്യാനാം ഹയഗ്രീവ ഉപാസ്മഹേ ഹയഗ്രീവ ഉപാസ്മഹേ.
Rebooting the Brain, powered by PRS Neurosciences.
एक वर्ड ध्यान रखना, बी फास्ट.
Asatoma sadgamaya, tamasoma jyotirgamaya, mrityormam amrutam gamaya. Om Shanti Shanti Shanti. This shloka is one of the big drivers for me to do what I'm doing in life every single day. And as the shloka says, from ignorance, we want to derive the truth, from darkness to light, and from death to immortality. This can be adapted to any field the way you want it. Hello, everybody. My name is Dr. Sharan Srinivasan. I'm a stereotactic and function neurosurgeon from Bengaluru, India. Today is our first day on a new journey. A journey of running our own podcast in neurosciences. Probably the first time in India and very few in the world running a dedicated podcast like this. So I'm seeking the blessings from all the elders, the gurus, and the wishes from all of you as we go down this path of educating people, creating awareness on a very, very sensitive yet unknown topic of neuroscience, which is about the brain. Okay? And today, to talk to us for the first time, we have an unbelievable person. But before that, you saw this video that played just now, our famous MSD, which is MS Dhoni. That stumping, the speed, the lightning stumping was unbelievable. Do you remember that stumping? It's amazing. Next, you saw the running between the wickets. Somebody measured that and said that 20 meters that he ran, if you translate that to 100 meters, it is faster than Usain Bolt ran his 100 meters in the Olympics and broke the world record. So MSD is our own Usain Bolt. But then, it's very interesting, before I go down that path, let me introduce you to the MSD of neurointervention in India, the Dhoni of neurointervention, my good friend, Dr. Vikram Huded. Vikram, welcome to our show. Vikram is the head of neurointervention at Narayana. I'm now invite him to tell about himself a little bit. Vikram, can you just share your thoughts?
Yeah, it's a wonderful initiative. I think it is important for neuroscientists to talk about the subject-specific things, because otherwise you can see many things. For example, my mother will send a reel about treating brain stroke, that if you put needle to the 5 fingers, the stroke will improve.
Really?
Yeah. So she will send those things. I think in that way, it is a wonderful initiative. I think we neuroscientists who are in this field should talk about this. That's how the public will know about the real fact, the evidence-based science. So I am Vikram Huded. I am Director of Intervention Neurology in Narayana Group. And I thank you for giving me this opportunity.
It's our pleasure. So I want to first start with that recent video that you shared about MSD, MS Dhoni, on not cricket, interestingly. And he was in a suit, very different attire, very serious. But he spoke about a very important topic and appropriate for him. He spoke something about be fast. We all know he's fast. So what is he talking about, be fast in a suit and not in a cricket dress?
Yeah, so it is important to create awareness about brain and the symptoms of brain disorders.
I agree.
So brain stroke, according to World Stroke Organization, is the second leading cause of death. Okay? So 1 in 4 people will have brain stroke in their lifetime.
Oh, 1 in 4.
1 in 4. So whereas everyone knows about the cardiac condition, they will have chest pain and they rush immediately.
Correct.
The problem with brain problems is it is a painless condition. Okay? And people don't know that it is a treatable condition and we can prevent it. And brain has various functions, and how people should remember the symptoms of brain disorder. So one of the common brain disorder is brain stroke.
Correct. Which is why we are talking about that today.
Yeah.
Yes.
Stroke, people sometimes confuse it with the heart.
Correct. Cardiac stroke, they say.
Yeah.
I agree with you.
So that's why stroke means it is usually related to brain.
Only.
So brain stroke.
But there's some brain attack, people use that word.
So brain attack or brain stroke or stroke, everything is related to the brain.
Correct.
So how a common people will know about the symptoms of stroke?
Okay.
So for that, be fast terminology has come.
Okay.
B is for balance. If there is any sudden imbalance or dizziness, if a person is having. E for eye vision, like blurred vision or double vision. Suddenly, if any person has these things, it could be one of the symptom of brain stroke.
Got it.
F for facial asymmetry. If you ask him to smile, it will go to one side. Okay.
Got it.
A for arm weakness. It means if you ask him to raise both hands, one hand goes down.
Got it.
S for speech disturbance.
Correct.
Okay. Suddenly they can stop speaking, or they can start talking irrelevantly. Okay. Some of the patients, they've gone to even psychiatrist.
Really?
Yeah.
Are you serious? I can't believe that.
Yeah. So that's why the symptoms are so varied.
Yeah, I know. That's the problem.
Yeah, and the brain has got wonderful functions and different functions. So that's why this mnemonic "Be Fast" has come. T is time to rush to stroke ready hospital. Because every second counts in brain stroke.
Perfect. I just want to stop you here. What is a stroke-ready hospital?
Yeah, stroke-ready hospital, usually what happens in general
But they go to the nearest nursing home.
No, I will tell you a story. Okay, for example, someone is having weakness of one hand. Okay, suddenly what he will do, he will call his friends.
Correct.
Friends will give them advice. Okay, mostly you would have slept in abnormal way. You don't worry about it.
Massage.
Yeah. And in some cases it improves also. Those are all TIA or minor stroke. But some people, if it is not improving, then they will call their family physician. The family doctor will be busy.
Correct.
Or he will tell you, come to my clinic.
Correct.
Then they will go to this clinic. Then he will write for investigation. That investigation, they will go to a lab. Okay, in lab there will be queue. And finally, when they diagnose it, it will be more than 24 hours.
Correct. They just go back and collect the film and the report.
Yeah. So that is a time which is lost already. So you can't do anything beyond 24 hours, right? I think research is coming beyond 24 hours also. But 24 hours we can consider as a golden time. Okay. So in stroke-ready hospital, what happens is if a person reaches a stroke-ready hospital with a symptom suggestive of stroke, they activate a stroke protocol. Okay. Immediately, blood test will be done. Okay. The scan will be ready. They will shift the patient to the scan. And they do the scan because we need to differentiate whether it is a brain hemorrhage or ischemic stroke.
Correct.
And we give the thrombolytic injection in the scan room only. And if there is a large vessel occlusion, we shift the patient to cath lab.
Correct.
So this process, how fast do you think it can be done?
I'm honest. I've been asking myself this question in our hospital, how fast you do it, but we're not able to maintain the same time 24/7 by 365 because different people are there.
Yes.
Everybody has to be sensitive.
Correct. So that's why it is a teamwork.
Correct.
And that's why that protocol should be optimized and it should be audited. So we maintain door to IV thrombolysis time, door to puncture time, and we do the audit these processes every 6 months or 1 year.
Very good.
Okay. So now there are external agencies who come and do the accreditation of stroke center certification that we have started in association with the Indian Stroke Association and World Stroke Organization.
I see.
So these processes are important.
Agree.
So the fastest we have done from door to needle time is 13 minutes.
Whoa, that's amazing.
Yeah. So,
That's
but
amazing.
still we can optimize and do faster.
Agreed.
And the international standard says the door to needle time is around 60 minutes.
60.
And door to puncture time is 90 minutes.
Okay.
So that's why it is important that stroke-ready hospital, we need to identify, we need to know the symptoms of stroke so that the people will recognize the stroke-ready hospital and they reach in time.
Got it.
As you know, brain is one of the organ which can't be transplanted. Correct.
One Italian doctor was trying to do something. Remember, 1 year ago, everybody started sending me that. Doc, what do you think?
So that's why it is important. All organs in the body, this is my favorite line, all organs in the body we can replace. Heart, lung, kidney, liver, everything.
Correct.
But brain can't be replaced.
Only one has been successful so far.
So everyone knows, but for that, you have to go to Shiva for getting operated.
Yes.
For as a common being, as a human being, it is important that we need to save our brain.
Absolutely.
Okay. If we save our brain, the recovery will be faster. We can do good rehabilitation.
True.
And they can come out with a good functional outcome.
Absolutely.
So heart attack, you can see either if a person has a heart attack, either he will survive or he will die.
Correct. It's all on black, like a black and white situation.
And there are various techniques where they can survive and they can go back to their job and do all that.
Even if his heart is weak, they can still go back and do reasonably well.
Correct. But regarding the brain problems, regarding mainly brain stroke, see, if a person is disabled, they will be bedridden.
Very true. Very true.
And one more person in the family is required to look after that patient.
Correct.
So the whole family will be disturbed. So that's why it is more disabling than heart attack.
Very true.
So that's why it is important that we should know about these conditions.
Correct.
And the good news is that it is a treatable condition and we can prevent it also.
That's the message that we want to give, that don't give up. See, a lot of people, stroke organs, they think that their life is gone, is going to be disabled for life, and this is what's happening. And that's a very valuable message that you have given. But like I also say, adding to what you said about the brain and the heart and things like that, today with 100% brain working today, it's difficult to survive in this world.
Correct.
Imagine if 5%, 10%, like a mobile phone, little bit slow, one signal less, WhatsApp, everybody gets restless, what is going on and things like that. So people want efficiencies and efficient organs working. So this be fast, I understand at one level that, Dhoni said, you look at yourself and all of those things. But just being fast and understanding at home is not good enough. They have to be fast in getting somewhere. You said the door to needle time. The moment they come to your door, you do that. But they should reach your door.
Correct.
And with this Bangalore traffic today, it is like... So that is why this nearest stroke-ready hospital. But what I want you to give a little more details, what does a stroke-ready hospital actually contain? Because nobody puts up a board, I'm a stroke-ready hospital. I don't think, even my hospital, we have not put that board, technically.
Correct.
We say we treat, but we're not put stroke-ready. So what should a public who doesn't understand a stroke-ready, what should they look for? Especially it's on a weekend or non-business time.
Yeah. So one way of looking at that is people should know the symptoms of stroke. Then even we should have a system of ambulance system where we are going to training the drivers and the assistants who are there, paramedics in the ambulance system. They should know the nearest stroke-ready hospital. In stroke-ready hospital, it is very simple. Okay, there are primary and advanced stroke centers. In primary stroke centers, a CT scan, which is there in every district now,
correct,
that is required.
But become like an X-ray now, actually.
Correct. And you should have a clot buster injection. And a neurologist or a physician or a doctor who is trained in treatment of brain stroke. That's all is required.
Oh,
it is
good.
A simple process.
That means we can roll this out anywhere in the country.
We should. Yeah. And every district, every taluk should have a stroke-ready hospital.
Fantastic. But is it happening right now? I don't think it has. No?
Yeah. See, in India, the thrombolytic rates is around less than 2%.
2%? Huh?
Less than 2%.
Wow. Thrombolysis means the clot busting that they give in that
which is there since more than 20 years.
Sure, I can't imagine. 2%.
Yeah.
That means out of 100 patients, only 2 are getting it.
Correct.
Where 100 could have got it.
Yes. And slowly, this is improving. For example, in Bangalore, now the awareness is much more.
Correct.
Okay. And they're reaching the hospitals. The thrombolysis rate is improving. And the thrombectomy also, it is improving. The thrombectomy is minimally invasive pinhole procedure.
I'll come back to that.
Okay.
We'll finish this B fast before we go to the procedure.
So main thing is they need to reach at least a stroke-ready hospital, which is a primary stroke-ready hospital, where we can give thrombolytic injections, clot buster injections, which is simple injection. What is the minimum requirement which is required? You just check the sugar, because sometimes hypoglycemia can mimic a stroke.
Correct.
And do a CT.
Correct.
Rule out a bleed and give thrombolytic agents. And so the window is around 4.5 hours time window.
So again, the question is, like you say, it's painless. So the urgency is not the Solpathnor and let me see what is going on. They'll do all of these things. So there's also this concept that all of us talk about very famously, which is behind me, is called the time is brain.
Correct.
Now, what is this time is brain? We don't say time is heart, time is kidney, time is liver. I think so. Only for the brain we're saying time is brain. What is this time is brain? What is this urgency? Why are we, harping about this?
Yeah, because once the blood flow to the brain is blocked, the neurons in the core, which is the center part of the brain, starts dying. Okay?
Correct.
So the rate of death depends on the collaterals. Collaterals are additional blood supply, which is given to that part of the brain.
Correct.
Okay? So if collaterals are not there, the brain starts dying fast.
Very fast.
Okay? So as you know, once the brain cells die, it won't regenerate.
Correct.
Okay? It is dead end. That's why... And you can't replace the brain also.
Correct.
So you need to save the brain as much as possible.
Got it.
The earlier we open the vessel, the blood flow to the part of the brain is restored.
You have to restore the blood flow.
And we can save that part of the brain.
Got it.
Okay, and then slowly the functions will be, we can train that part of the brain and the recovery will be faster. So in one study, if collaterals are not there, every second we lose around 32,000 neurons. Okay.
100 billion, no? That 100 billion is a rough count of the number of brain cells. That's what I read.
Yeah, I think 130, I don't know.
That's what, above 100 billion.
Yeah.
Nobody can count it. It's a guesstimate.
So main thing is we need to save the neurons, so that the recovery will be faster.
That's the goal.
So if the collaterals are not good, it is so fast. If the collaterals are good, we can extend the reperfusion therapies up to 24 hours time.
God. Up to 24 hours.
24 hours.
So that's a decision you make looking at the MRI. We'll come to that a little later, how imaging helps us to make those decisions and prognosticate. So what you're saying, just to sort of recap to our global viewers, is that number one, you have to be fast in diagnosing the problem. And once you feel that you're suspecting, it's better to be overactive than underactive.
Correct.
Rush to a stroke-ready hospital that's closest to you so that those times that you save.
Correct.
And then from there, you make sure that the right treatment is given as fast as possible so that the maximum neurons are saved. Perfect. Now, you also mentioned a word called thrombectomy. You understand just now, and I said we'll come back to that. Now, I know, you've just been voted, congratulations for that, as the best neurointerventionist in India. I think that's amazing stuff. I know, and there's no question that, that you have been doing human service in this for a long, long time. What is this neurointervention? Because today what happens is there are patients coming to me with varicose veins, saying that Nara problem, doctor, Nerska problem, which means that people don't even know that vein and nerve are two different things.
Correct.
So that is the level of people's and educated people. They're not, and they get upset when you refer them to somebody else. We came looking for you and things like that. So I think the audience need to know that what is this that you're talking about, and where do you give IV thrombolysis, and where do you do the thrombectomy that you're talking about. So before that, what is neurointervention field? Please start with that.
So, as you know, in the body, there are two types of blood vessel. One artery, which takes the blood from the heart to the various organs.
Correct.
That is called artery.
Correct.
Where the pressure will be more.
Correct.
What we check the BP is the arterial pressure.
Correct.
So, there is another type of blood vessel, which is vein, which brings the blood back to the heart.
Okay.
So, it is a soft, and it brings the deoxygenated blood back to the heart. So this is the basic two things. So there will be arteries to the brain, and there will be veins to the brain, and there will be arteries to the spine, and there will be veins to the spine. So in neurointervention is a field where we do pinhole procedures through the artery or the vein for the disorders in the brain and the spinal cord, mainly for the vascular axis. So vessel related.
Where is this pinhole you put in the brain?
No. So we put a pinhole in the leg artery or in the hand artery. So from there we reach the brain. We use fluoro guidance, which is X-ray, to reach there. So that is a technique. It is a pinhole procedure. Some of the procedures we can do in the morning and they can go in the evening. So that's how advanced it is.
Like a daycare procedure.
I think that's how the field is. And it's a beautiful field.
I agree.
And so the first cerebral angiogram was done by Ijaz Moniz.
That's it. I know.
So he got the Nobel Prize.
I know.
And,
but not for that. He got a Nobel Prize. He got for something else. I remember. Yes, I remember that.
Lobectomy.
Yes, functional lobectomy.
But he's the person who did the first cerebral angiogram.
I agree.
From there to the present field, it has evolved significantly. Now we have robotics doing where we can do neurointervention using robotics. The field has evolved significantly.
Technology. I think we healthcare individuals will talk a little bit later about that, but I think we are a little late off the block to adapt technology into our field. Because we felt, I used to always tell the engineer, in our field, 1 + 1 is never 2. You have to understand this. For you engineers, is only 2. For us, it's any other number except 2. Please understand our problem and so on and so forth. I think some more and more engineers are trying to get that perspective and make it more doctor-friendly, I think, to make it different. So coming back to thrombectomy, which is the end of the BFAST patient appearing in your emergency. So what do you do in this thrombectomy? Or, what is the goal of this thrombectomy, or what do you do?
There are two types of stroke. One is because of the blockage of blood flow to the brain, which is called ischemic, which is more common, around 85%. Second is brain hemorrhage, where the blood vessel ruptures.
Correct.
So once the blood flow to the brain is blocked, if they come within 4.5 hours time window, we do a scan and see that the vessel is blocked, larger vessel is blocked, and there is no hemorrhage, and we give the thrombolytic injection.
Correct.
So in this thrombolytic injection, if the clot size is more than 7 millimeter, the recanalization rate or
There's an opening up.
reperfusion of that part of the brain is reduced.
The opening up of the blood vessel.
So in those conditions, what we do, we put a pinhole from the leg artery. We go inside the blocked artery,
Okay.
which a bigger catheter. Through that, we put a smaller catheter. We cross that clot using clot retrievers, and we pull the clot out.
Got it.
That is one way. Second way is like a vacuum cleaner. We put a small aspiration catheter, go proximal to the clot and suck it out. So this in the
And
this
you
way,
open it up.
we can open the blood vessel and the recovery will be fast.
Amazing. How putting a puncture here, going all the way to the brain, without technology, without vision, it's impossible. That's why we said evidence-based science,
Correct.
to do all of these things. So I want to give you one story I had done recently, right or wrong, good or bad. There was this, I got a call from Bellary one day saying that one high profile, person's brother-in-law had a suspected stroke, and within an hour, and they said, I'm bringing him to Bangalore. I said, again, you can't come to Bangalore because I know the driving time is 5-6 hours. You'll be out of window period. Why don't you go to a local hospital?
Correct.
Unfortunately, there's no stroke-ready hospital there. At least they didn't know about it. And they said the doctor is here only. I spoke to the doctor, the MBBS doctor. He says, sir, we don't have anything here. He has to come to Bangalore and things like that. I said, no, what do I do? Now, this guy's high profile. Now, if I give the wrong advice and this fellow dies or something else happens on the way, then it becomes responsible for me. I tried to dissuade him to come. I said, go to the nearest place, maybe go to Davangere, go somewhere else, but get at least a diagnosis done and get CT was normal, okay? Or at least get the injection done. And this guy did listen, sir, we are coming. And he sat in his car, he had ordered ambulance and started coming. I said, hi Ram, what is this going to go? Then I had to activate a plan. Then I immediately called somebody else and said, guys, this is going to be a disaster for us if this guy has a permanent stroke. So I took the clot, I got a clot busting injection. I took a nurse, I sent him in an ambulance from here. I said, no, you guys like this James Bond movie,
correct.
catching that guy. Somewhere near Shira, they met. You won't believe it. I put him in the ambulance, gave the nurse to give that injection in the ambulance and brought him here. And it sounded exciting for people. It went off well, so it's okay. Suppose it had not gone well, then I would have been responsible. I was just praying God, that those things happen. And about praying God, you said, when we are chatting outside, that sometimes when tough cases, I'm quite sure that, you are such a high profile interventionist. I'm quite sure a lot of tough cases are coming to you. That's what is going to happen as a part of being successful.
Correct.
So what do you do when you're in this situation like this? What goes through your mind? What is your, psyche and things like that? Can you tell the viewers?
See,
because you're also a human being at the end of the day.
Correct. So sometimes the thoughts will come, negative thoughts, whether the outcome will be good, bad, all those things.
Correct.
So simple way is you need to surrender to God. Okay?
I agree.
You need to think that you will put your best effort. The outcome will be decided by Him.
I agree.
Then you can relax.
Amazing.
And I think I think most of the interventionists or surgeons, we are addicted to work. Okay.
I agree.
Why we want
Nasha, I call it a Nasha. Actually.
Yeah. So why we want to work is we enjoy the process.
Agreed.
Okay. So that is the time where your mind is calm, peaceful, no thoughts.
Correct.
And it is like a meditation.
And no distraction also. Yes.
Correct.
You're in the zone.
And that attracts us. And that's why we are addicted. And that nowadays that work-life balance and all, I think if you enjoy your work, you will love doing it.
I agree. I totally agree with you, because when I was studying to be a doctor, Tendulkar was in his peak, and in some interview you had given about this zone. I was in the zone. I was wondering what is this zone business he's talking about, because we were still sort of getting many years later when I get into zones like this and certain things, when entire noise outside is completely filtered out, you have no clue what is happening there. That's when you really realize that being in the zone is very, and like you said, you don't feel tired.
Correct.
You come out rejuvenated rather than it's very interesting. Maybe the adrenaline pumping or whatever it is. I think so. I also tell a lot of people when we see death every day, as you understand, as in our field. We get all spiritual, and I tell my patients usually, and even what Krishna told Arjuna and Mahabharata is, you fight to win, But eventually the result is there. But if you don't even get to the battlefield, there's only one result.
Correct.
So you have to eventually play the game. You have to do what you have to do. But, getting stressed out about the result, I think it's an amazing attitude that you have professed. And I do that myself. And I think we should tell the viewers that that's one definite place to be. Do the basics. And all successful people say the same thing. So can you give me any story of some intervention like this that who came in some, can you give anything that comes top of your mind that which you are excited about, or maybe your earliest case or some good case or something like that?
Yeah. So one of the, I think, police person, he reached our hospital in 1 hour time.
Okay.
So he was not able to talk. Okay, and he was not able to move his hands and legs. So we did the scan and we started the thrombolytic injection, shifted to cath lab. And so sometimes if a patient cooperates, we do under local anesthesia.
Correct.
We removed the clot, and on table he started talking.
Amazing. Oh.
Okay. So in neurology, such magical moments are very less. Usually, the outcomes we need to see after 3 months or 6 months.
True.
So such cases will inspire us. Actually,
I agree.
So a person who is not able to talk and not moving the limbs, and you do this procedure, and you start talking, and he started lifting them. So this happens in around 10 to 15% of patients, around 24 hours time window. So the good news is, on that day was my birthday. He wished me on
Are you
table.
serious?
Yeah.
Fantastic. Amma, what else can we expect?
Correct.
No, that this Nasha, no money, nothing else will give us. Yeah, that thing that you see about these patients coming up, I can see that joy.
So,
I agree. I think that's what keeps us going. And then, like when I keep hearing this, many of these guys saying, "I want to retire at 40." I said, retire and do what? Correct? No, because I said there's no fun in, because we have such good skills that we want to help patients get better. Fantastic. I think that's a very interesting story. So now there's a thing that we call in the blood vessel architecture called the circle of Willis.
yeah.
So as a neurosurgeon, I'm fascinated by that, how God has created. I always tell everybody, God has created this human body for surgeons or intervention, because He's done it so well. We are only using what is available to do all the drama that we do. Yeah. But if we didn't have that access, there's nothing that you or me could have done, putting a puncture here and going all the way to the brain. But you also mentioned collaterals, no collaterals. So can you tell the viewers in simple words, what is this collateral? What is the circle of Willis? Why is it so important? How God has created it, and what how you use that.
So circle of Willis is a connection between the arteries inside the brain. I think it is like internal bypass. Some people have it, some people don't have it.
Okay.
So I think the people who have it, the outcome is better.
Okay.
And God has created the brain, and the blood supplies to the brain is phenomenal. Even human body is phenomenal. You can create anything, but you can't create a body, or you can't create a brain and the blood vessel, how it goes and how we think. That can never be created.
I agree.
Correct. So in the circle of Willis, blood supply to the brain, there are 2 arteries in the front and 2 arteries from behind.
Correct.
And inside the brain, they all get connected with. Because even if one artery fails, if the collaterals are there, if that circle is maintained, it starts giving the blood supply.
It's like getting water from the neighbor's house.
Yes. And some people can survive on one artery.
Really? You've seen that also?
Yeah.
One of the 4?
One of the 4.
Whoa.
If the vertebral one of the artery is big, it can supply the whole brain.
My goodness, amazing, yeah.
So again, the failback system is already there, designed, inbuilt. So if one system fails, already there is a backup. Amazing. In that way, the circle. So these are all the collaterals. Collaterals is in the circle of Willis, and non-Willisian collaterals are pial collaterals. Correct. Means the MCA branch can give supply to the ACA. The PCA can give supply to the MCA or ACA. So these are all the collaterals.
The external characters. Sometimes with the external characters.
Dural pial collaterals.
That's right.
The durals can give supply to the pia. So these are all the alternative process where the nature tries to save the brain. So, but still, I think in some people it fails. In those things, we need to reanalyze. So those are the cases, and we can't predict it. I think in future, the AI may help us in identifying these things. Already AI is there in stroke. And yeah. In the imaging, I think rapid AI is the one which is standardized and studied in RCTs.
I see.
And it can identify in some of the cases, not a majority of cases, how much is the brain which is damaged and how much we can save it. So it gives the result in 5 minutes time.
So it's like a prognostication tool.
To identify patients whom we can do thrombectomy. And it is standardized.
Oh, very nice. Very nice. So now you spoke about thrombectomy in a stroke and that police case. I mean, I'm quite sure a lot of people are there like that, and some of them do get better over time. Now, what else do you do in an acute stroke intervention? One you said was IV thrombolysis. The second one you said was thrombectomy. Are there more complicated cases? Something more has to be done in some certain patients? And if yes, what?
Yeah, so in ischemic stroke, coming to thrombolysis window or thrombectomy window, in that space, in some of the cases, we see blockages. Okay,
like in the heart, you get a block in the heart.
So the blockages can be in the neck or it can be in the brain.
Okay.
In those situations, we remove the fresh clot using the clot retriever or aspiration.
Correct.
And there is underlying plaque, which is a cholesterol deposition. Okay.
That's the long-standing one.
Long-standing one. On that, the fresh clot develops. That's how the stroke in some of the patients.
Correct.
In those conditions, we do angioplasty.
Okay.
And in some cases, we put a stent also.
Got it.
Yeah. So it can be done inside the brain, which is called intracranial angioplasty and stenting, or it can be carotid stenting.
In the neck.
In the neck. So these sometimes we do in the acute situation. Otherwise, the artery will collapse again.
So that when you do the angiogram, you study all of these things. So you're going with the multiple plans in place. You have to be very aware that every patient is different, the data is different, and on the feet, you are thinking like this to know what is going on. Interesting. Now, what is the challenges of putting a stent in the brain versus stent in the heart? Because you hear it very commonly, I put 3 stents, 4 stents. Somehow I feel that it doesn't translate to the brain like a thing.
So cardiac arteries are stronger.
Okay.
Because the architecture, how it is built is stronger. It can withhold many things.
Okay.
The balloon, they can use a stronger balloon.
Okay.
So brain arteries are softer. And even one little bit of air, if it goes, or clot it goes, the outcome is not good.
So it goes off behind.
So that's why it is, each organ is different. We need to study the organ, what are the outcomes, everything. And they are softer. So if you do a big balloon, it can rupture.
The blood vessel.
The blood vessel can rupture.
Like a pipe breaking.
Yeah. So the brain blood vessels are different. They are more tortuous.
Okay.
It is difficult to take the materials inside. Now with technology, it has improved. We have got very good materials. Because of the R&D and all those things, and the techniques have improved significantly from 20 years back when I started presently.
It's like the phone, no?
Yeah.
We had that small phone when we were kids. I don't know whether it was there when you were there. You remember the dial phone?
Yeah.
And from there to where we have come now is amazing. It's just incredible. So technology is impacting every field of our life, every single moment.
Correct.
So now that you have said so much about stenting and clot busting, I want to bring your attention to one Facebook post came up a few days ago of a procedure you had done in 2014 of a 6-year-old child who had a stroke. No, really? A 6-year-old child stroke? I mean, always we think stroke is an older person's. Actually, in fact, people think after 40, 50 it happens. We are seeing younger stroke, but 6-year-olds too much. Is there something like that? Was it an unusual situation?
No. Stroke, that is one of the myths that brain stroke happens after 60 years. Okay. Brain stroke can happen from day one child till 100 years. So anyone can have brain stroke.
Oh.
So earlier, because of the people lifestyle, and we used to see more than 60. Now we see 40 is common. brain stroke is common in 40 years of age.
True.
And it can happen in pediatric age group also.
But is the causes the same or the causes are
No,
different?
the causes are different. It can be because of some cardiac condition, or there may be some dissection,
Okay.
like the child is playing and a football hit, and then the artery can dissect and that can produce a stroke. So the causes usually in after 40 years, it is lifestyle related problems like BP, diabetes, hypertension, all those things. Whereas in pediatric age group, it is a different condition. Maybe the blood vessel may be abnormal, or they may have some cardiac condition where the clot goes
from
inside.
the heart goes to the brain.
So
This child had what? This particular
so this child had a dissection of one of the vertebral artery, and where the clot went inside the brain, causing the child to go into complete coma. So even though the child was given maximum treatment, on that the child was deteriorating. So in those situations, only we treat, and I think this was one of the first case we did in India. During that time, there were no guidelines. Okay, so means we only clotbuster injection was approved, and we used to go inside the brain and give this clotbuster injection inside.
Correct.
So that was intraarterial thrombolysis.
Correct.
So that we used to give over 2 hours time, and it used to
like an infusion. Slowly, like a drip.
So in around 60% it used to open, and it never used to open. So we used to try this, and when it failed, we heard that there is a device where thrombectomy can be done. So it was available in India, but it was not proven.
Okay.
So then we started using this, and once we used it, it was like magic. I said the first case which we did, I think in 2010. So we gave that thrombolytic injection. It was not working, and then we removed, and the patient improved significantly. And it was not believable, and many people didn't agree that we can do such cases. Then we started using. Then even in pediatric, this child who was in coma, we removed the devices. We used adult device only, but we can deploy half of it and removed it. And now the child
has to be done
improved completely and went to school.
Fantastic.
So from coma to school is a significant change.
Amazing.
So, but we should be careful in pediatric age group because sometimes it should be very selective, and selected cases. Now it is proven beyond. And there are guidelines that we need to do thrombectomy.
Correct. So initially, I was in a Viksit Bharat the talk recently, and I was showing some of my surgical results. And somebody asked, these risky things you're doing. Then I mentioned something called you should have a leap of faith. And that man was actually a statistician, data scientist, and who only believes numbers. So when he heard somebody talking about leap of faith, he said, "Doc, tell me more about leap of faith. How do you do that?" I said, "I don't know how I do it. I think it just come correct. No, it's very difficult for us to articulate what a leap of faith means." Correct. And it comes back to what you said. You have to, surrender,
and put your effort.
Yes, that's I agree. Because the not putting effort has only one result at the end of the day, for sure. Coming to you showed the neck and dissection. Is that one case we had a very tragic ending was that cricket player. You remember that guy Phil Hughes from Australia, who got hit with a bouncer on the back of the neck, and just there he collapsed and died on the cricket field. And now they have that special protection. I don't know how many of you of them have even noticed that the extra protection is there. So with bad results, everything people try to innovate to make sure things get better. So childhood strokes.
Correct. But this dissection, you need not play cricket. Okay, it is so common that during head massage, like when they go for salon barber, so that is very common.
Really?
When they
see that? I have not seen.
We see.
My goodness.
So again, it is whenever I go for salon, I educate them. Don't touch my neck. Okay. So some people will develop stroke. Some people will develop stroke. So that is a dangerous thing. So don't think that while playing football or cricket only you can have dissection. People who do massage, sometimes if there are abnormal arteries, if you do sneezing, severe cough can dissect the artery. It is not very common. but it is not that uncommon also.
But as you spoke about the child at the stroke, one thing comes to my mind is when I was doing my fellowship in Japan, Tokyo Women's, they have this disease called moya moya disease. So, do you see moya moya in children here? As much as we saw, we used to see so many children, 1 year, 1.5 years undergoing surgery.
Yeah, so in our center, we see it often, means maybe monthly 1 or 2 kids.
Really?
Yeah. Because they're all referred.
Okay.
So otherwise,
because you're a referral center.
Otherwise, in general, the incidence is less.
But what is this moya moya? What does actually? Just for since I mentioned it, might as well ask you.
Yeah. So moya moya, what happens? It is a condition where the blood vessels inside the brain start becoming narrowed.
Okay.
It is not an inflammatory condition. It is not because of the plaque deposition. We don't know. Some cases are genetic.
Mm-hmm.
So again, once it starts becoming narrow, there will be collaterals which starts helping the brain getting blood supply. And in some cases, we need to do bypass surgery, where we take the blood vessel from outside and join it inside the brain.
I saw that. There was one Japanese neurosurgeon where I trained for my functional neurosurgery. Very adept at this. So vessels are so small. I was watching him. I was doing a 1.5-year-old child. Bilateral bypass he was doing. He turned this side, he turned this. I said, wow, you weren't under microscope, you were looking so small.
Yeah.
It's quite frightening. Moya moya, he was saying, is like a puff of smoke. The blood vessel looked like a puff of smoke. So childhood stroke is quite an interesting situation. Oh, we spoke so much about it. I think so. But, I was sort of, having a little bit of increased heart rate just listening. As much as I do trauma, I agree with that. But that time, it becomes so critical, to make that happen. So how do you do any breathing exercises or something like that apart from you being calm? What do you do? How have you built in some principles to keep your sanity at the end of this whole process when especially going on? What do you do?
So I think Timappa Hegde, he's our director. He has initiated me into spirituality. Oh. That helps a lot. So you should do meditation, walking, all those things, and mindfulness. I think that is the one which you should observe your everything around outside and inside.
Correct.
I think these are the processes which help in controlling your emotions, thoughts, all those things.
Fantastic. So I know I'm hoping one day I'll get Professor Timappa Hegde on this show, hopefully to share his view, because I did during the COVID time, he ran that Bhagavad Gita classes and we were there and seeing how it goes on and things like that. So the last bit of stroke is about spinal cord stroke. You said brain stroke, this, that. You did mention casually about spinal cord. Is there something even called a spinal cord stroke? Is that possible?
So brain stroke as definition is the blockage to the blood flow to the brain, retina and the spinal cord. So anything...
Oh, retina is also part of brain stroke.
Yeah. So because retina is the extension of the brain.
Correct.
So these three things, when they are affected by acute problems, it is a stroke. So spinal cord also, suddenly they may develop weakness in both legs, but it is very difficult for people to analyze and come to the hospital within 4.5 hours with the spinal cord stroke. So usually they come late.
I remember one vivid story when I was doing my neurosurgical training in the Manipal Hospital. He was a 9 or 11-year-old boy. He was playing football and suddenly he developed some weakness, and within a few hours he became weakness both legs, paraplegic as what we call. And he was a doctor's nephew in Mandya. And by the time they figured out and they were out of the window period, but he had a spinal cord infarct. And he found that he had some AVM and, we had to deal with all of that and things. So we'll go down that path a little later. Okay. So we covered a lot on stroke, and looking back and all the technology, it has really helped you to move faster, get better results, reduce complications, and I think which is what it is Do you think in the last 20 years that people's awareness of this clot busting injections and this has gotten better, at least in cities like Bangalore?
Yeah. Definitely, I think through Karnataka Stroke Foundation and Bangalore Stroke Support Group, we have done a lot of activities.
Okay.
With that, the awareness among people has increased. So some people will come, sir, that injection kortiralla adu kodi.
Correct. So
After 24 hours, they will come. So I think awareness has improved
At least.
definitely. I think it is
the be fast has to happen. No? At least the awareness is there. Very nice. But see, we always say, I always say, and I always hear, Bangalore is like the startup capital of India, unicorn capital of India, all those things. So anything new happens in Bangalore first. So you saying Bangalore, people are asking, is good. But has this translated outside Bangalore, outside the state? Because we always see so much of difference in the level of care between, one area to another area, especially India being such a big subcontinent. What's been your experience? You have traveled everywhere in India for sure to give talks on this. What has been your experience going to different areas?
So I think a lot of associations have come up and they are doing activities. And each district, I think the vision is each district should have a stroke-ready hospital.
Okay.
At least thrombolysis and in future.
Is it from the government that initiative is coming or?
No, Indian Stroke Association and Karnataka Stroke Foundation. We are doing, in each districts, we are doing annual conference. In that way, we call all the physicians. They will be aware of it.
Nice.
And Indian Stroke Association, they are doing a lot of activities. With that, the awareness is building everywhere. But again, it is focused. It is focused mainly to the metro cities. And slowly now in other cities, other districts also, it is coming. For example, Davangere, they have started doing thrombolysis. Like that, many centers are coming up where they started doing thrombolysis and people come there for the treatment. So awareness is gradually it is improving.
But what about outside Karnataka, like for the Northeast or other locations?
Yeah, so again, Northeast, ICMR is doing projects. They have a CT scan, mobile CT, which is placed in Northeast, and they are doing thrombolysis. So I think even government is supporting about stroke, and they are doing many activities. And I think slowly it will build up.
I'm glad because one of the complaints I keep telling even my intensivists is why this stepmotherly attitude towards the brain. Everybody thinks heart is more important than the brain for some reason.
Yeah.
It is so depressing to see that, but I'm glad that so much is changing at the end of the day.
Yeah. Also, one good point always I will tell whenever I go to give a talk to the general public or companies. See, in annual health checkup, we always concentrate on the heart and the diabetes.
Correct.
Okay. People don't think about brain and unless it gets affected.
Yes. That's all it is.
So they can add a simple carotid Doppler in the annual checkup.
Very interesting.
Or if a person is having a family history of brain hemorrhage, they can do MRI scan, which is non-contrast, no radiation.
Correct.
Every 5 years. If there is a strong family history of brain aneurysms, they can do brain scan.
Very true. Actually, having mentioned that, in Japan, again, I'm going back to this one there, aneurysms are endemic there. There. So they have something called a brain check for aneurysms.
Correct.
So every year people are getting brain checks, and that center where I was a high volume center for aneurysm surgery, and they were treating about 18 to 20 aneurysms every month, and out of that 95% were unruptured, not ruptured at all.
Correct.
And they would come because they say patient presented because of brain check. I said, how cool is that?
Yeah. So
I think you should translate here. I think
correct.
It's
ischemic stroke, according to World Stroke Organization, is 1 in 4. Okay, whereas study done in US, 1 in 50 people will have brain aneurysms. Okay, but brain again. When I did my fellowship in Europe, where I did, their majority of aneurysms, what they treat, 95% are unruptured.
Really?
Yeah.
I think in here India, it's the reverse.
Yeah, 95% of aneurysm what we treat is ruptured. So again, one of the story what I wanted to tell, my grandmother's sister, she had SAH at 8 years of age. She had 6 aneurysms. Okay.
What?
Yeah. So one of her daughter, she was in US, she was doing treadmill and she collapsed. She has an aneurysm. Then I told 2 people are having aneurysms. So we screened the other family members. We got one more aunt who had aneurysm, which I treated. So that's why it is important to know the family history, and we can identify that aneurysm before it ruptures.
Got it.
As you know, once the aneurysm ruptures, 15% won't reach the hospital.
I think so. What has happened is we jumped into SH without giving a context of SH. So now we have finished the stroke intervention, and it's perfectly, we have moved to the next segment, which is aneurysms, which is beyond. So don't think that Dr. Vikram only treats, stroke, acute care. He has lot of things that he has into that he treats, and we will definitely show the viewers the entire width of treatment he's doing, all the conditions that he's doing. So the second thing is he mentioned two things about his auntie, which is subarachnoid hemorrhage and aneurysms. So we know when we were training, subarachnoid hemorrhage or SAH is a bleeding in the brain, just for that simple reason. And we tell, if anybody who's conscious after an SH, the symptom he says is the worst headache of my life.
Yeah.
Much worse than a brain tumor or anything else.
Correct.
So I also say, because as neurosurgeons, we also treat aneurysms, when they don't intervene, we do clipping and all of that. And we say 1/3 of patients who have brain aneurysm die on the spot. 1/3 survive but remain unconscious and they remain vegetative, disabled, and 1/3 are lucky. In fact, our present health minister, his own brother had an aneurysm rupture many years ago. He collapsed in a hotel and he died. So there are a lot of stories like that, and we have another major news anchor in Bangalore City who he called me in time. We caught him in time. He went through a very rough phase, and he's doing very well back at work. So it is like this. In fact, before I give it back to you, I want to be a neurosurgeon from my 8th standard, okay? And that, when people ask me why, that inspiration came from reading Reader's Digest books. I don't know whether you know this book called Reader's Digest. And Reader's Digest used to carry one segment called, drama in real life, something that happened in real life. And that particular story was one high-profile lady who was skiing down the Swiss Alps, and she collapsed. And they airlifted her with a helicopter. At that time in 1980s, India is unheard of picking. I thought, whoa. And they found she had an aneurysm rupture. That's when in my 8th standard, I heard the word aneurysm. I never understood what it was, but I read the word for the first time. And they did whatever they did, and then she got well. So that fascinated me right from then. So aneurysm is like, a bobby in the brain that ruptures and things like. So we open the brain, we put clips and all of those things. What do you do in pinhole procedure for aneurysms? Can you tell our viewers that?
Yeah, so the various techniques which we can use to treat the brain aneurysm. Brain aneurysm is like, as you said, balloon-like swelling of the blood vessel of the brain. So if a person comes with ruptured aneurysm where it has burst, so we put a small tube from the leg, again go into the brain aneurysm, and we put a small catheter and we deploy platinum coils.
Okay.
So the platinum coils are very softer than the hair, and we go and put coils there so that blood clot is formed and re-rupture of the aneurysm is reduced. This is one way of treating the brain aneurysm.
Got it.
So sometimes if a brain aneurysm is unruptured, if it is a sidewall aneurysm, so we use a flow diverter stent. Flow diverter is a mesh. I always give example. For example, if water pipe is weak and it bulges, what we do, we change the pipe. Correct. So whereas in brain we can't change the pipe.
Correct.
So we put reinforcing pipe inside that pipe. So that majority of blood will flow through that pipe and the pressure on the bulge comes down and it will heal.
Got it.
And usually in 1 or 2 years' time, 95% of the aneurysms will heal completely and it will never come back.
Oh, it won't come back. It's called flow diverter.
Flow diverter. So, and if it is a bifurcation aneurysm, so we put a similar thing, we put intrasaccular devices, so which are called flow disruptors.
Oh,
we
I've
go
heard
it
of this.
and it is a reverse umbrella like thing. We go inside and deploy it.
Oh.
Okay. So these things can be done faster.
Amazing, no?
It can
I
be
don't
done
think
faster.
in the heart they do use any of it. Do they do all this?
No, they
It's all
don't use.
purely device for brain, huh?
For the brain.
Whoa, amazing. So how much has progressed? Initially we thought heart stent, expandable stent was such a great thing. No, brain I think has overtaken the heart. I think from the kind of different
Technique-wise,
different things that we have to make that happen. So just deviating from the topic of the heavy topic of neurointervention, just a lighter note, is we were talking in the morning as you were coming, about what do you do, and then we came to know that we had done a similar program called Landmark Forum to Education together.
Yeah.
So I did the Landmark Forum in the year 2000, and I went through all their curriculum, and they call it the curriculum for living. And I personally feel that it really nearly helped me get 15 years of my life back to do the way I wanted to be in control of my life, to what I am wanting, rather than allowing the society to push me to do what they think is the right thing to do. Sometimes all these pressures are coming from everywhere, Hangmad, all of those things. In fact, let me share with you, they keep asking you what do you want to achieve in the forum or whatever it is, that program. And before I went into the forum, I was very clear that I want to be one of the best neurosurgeons in India. And I'm driven, anything I take on. And during and after, I came to this conclusion that I don't want to be the best neurosurgeon. I want to be a good neurosurgeon, but the best father, best husband, and best son. So I redesigned my life to make sure I don't burn out, because I can't afford to retire at 40 years like many of these guys want to do prematurely, because we have a God-given skill that we think we should help more and more people. And that's how it has helped me. So what has been similar like this, you must have had some thoughts. What did you share some of your
I
thoughts?
think Landmark Forum was a very good thing I did in my life. I think so the main barriers are within us. So that's why I understood after that forum. And we need to break those barriers and think big. And we can create anything in life, whatever we want.
Absolutely.
I think the barriers are outside and barriers are inside also. So I think that was a very good thing. After that, I did many things, and you need to think big for the society.
Beyond you. Got it.
Beyond you and your family.
Got it.
So it is important that you need to give time to yourself, to your family, and to the society.
Got it.
So once you think beyond big, I think the universe will give you whatever you want. You think for others, and it will give you, and it will happen.
Like magic. Sometimes you wonder.
Like magic,
I agree. I agree with you. Very well said. Very well said. And you also made a statement that life is just an experience. What do you mean by that? It was a very profound statement that you made.
Yeah. So no, you have many mentors, and you can learn from each individual, every individual.
Very true.
You are asking who is my mentor. Everyone is an individual. I learn something from you. You should always learn from other people. Correct. So life, when we are born and when we die, we don't take anything. Okay, we are this moment, we are experiencing. That's all. It's an experience. There will be good experience. There will be bad experience. You need to experience. Every good, bad will have a time period.
Correct.
Okay, so that's all it is there in life.
True, very true. There was one important thing that you said was when you started, you were one of the earliest to come in, at least to this part of Bangalore. Or more importantly, you dedicated yourself to a science that was still fledgling. I know how difficult it is to pick up something like functional neurosurgery that I'm struggling to put it in place. And you have done, you put up your own fellowship programs, you've done all of those things. So see, I also see, a lot of people being very self-centered. I'm sorry to say that, but, saying that I don't want to teach this to somebody else. I want to be the Superman. I want to be the best. And so everybody comes to me and everybody appreciates me. But you have been selfless in, teaching people. So I've always been wanting to ask you this question. So today is the time to ask you this question. I know one Vikram Huded, but we need 1,000 Vikram Hudeds in India, or maybe more than that for the population that we are having, and we are only growing in the population, and they should be all over the place. So do you have a plan to, replicate yourself, or what do you call that?
So I think when you have a bigger vision about treating stroke, all those things, stroke can happen anywhere in the world or in India. So that's why you should have a vision, and you should have a good mentor and the leader who will inspire you.
Absolutely.
Okay?
Absolutely.
So I am blessed with Dr. Devi Shetty and Dr. Timappa Hegde, who are the leaders who will inspire you to do things.
I agree.
So I think that is one thing. I think for youngsters, if you want to work, you work under a leader who will inspire you and will get you best out of you. Okay, so in that way, you will also grow and the society will grow. So we started a fellowship program in NH, and now it is through DNB board. And I have trained many fellows. And initially, I used to select fellows from different states because earlier there was no awareness. So now fellows are there in Gujarat, Rajasthan, Jammu and Kashmir, Maharashtra. So like that, now through the society, we are started doing fellowship. Many fellowships, institutes are there. And
more like you.
More like you.
Oh,
more
nice.
institutes, and more institutes are coming.
Very nice.
So in that way, we are replicating so that more people will come out and start doing intervention there. I think when we started to now, and always you should follow your intuitions. I think so. When I started neurointervention, I think there were hardly few in India. So I took DM neurology in KM Hospital because they were giving fellowship program.
Why did you do that? What was on your mind? I know that I want to be a neurologist by 8th standard.
Yeah.
What was on your mind?
So that's what it was, just an intuition. Okay, that I want to do, and I read about it and started the journey. So it was a tough journey, but I enjoyed it. Okay, and now people are doing, and more people are doing. It is good.
I asked you another question when we were chatting offline, is that I want to be a neurosurgeon from 8th standard. When did you get it into your brain that you wanted to become a doctor, or what?
So when we do 12th standard, I think there was nothing fixed. We take PCMB and whatever you want to become engineer or medical. So these are the only two options available during our time.
Correct.
So I think I met after my 12th standard. I met with an accident. I got injured, and they took me to a doctor, and I got good marks in both. But everyone in family told you take up medical, and I said okay. Then journey started. We never did the career counseling. How was my brain? Whether I'm analytical or memory based. Nothing was done, and we put the effort. Correct. And I think that was the destination. And you will get hint, and you need to capture it and go forward. And the time when I started 30 years back till now, I think I enjoyed my journey.
Absolutely. No, I agree.
Yeah.
I mean, are you looking at retiring at all? Or?
No. I think that's what I feel. I think that is one of the addiction where you enjoy it, you want to do more.
I agree.
I think after going into spirituality, now I realized, I think with time, we can't do this for long. So I think anything what you do, if you put 100% effort, that is the time you will enjoy. Like drinking coffee. You be in that moment and enjoy. So I think
the smell,
that is the time where your brain will be relaxed. I think that is one of the things which we need to learn and go forward.
Well said. Actually, you said that you have no plan. Inspiration, like you said, was very important, because I think the current generation, what they lack is inspiration. They have too much of information. I think there's an information overload. That's what I believe that is hurting them rather than helping them.
Yeah.
And what they need is, and definitely, like you mentioned, Dr. Devi Shetty and Dr. Timma Bhakti, definitely they're inspiration for a lot of people in the healthcare industry. The way the important thing is to institutionalize what you do.
Correct.
See, you as an individual can only do so much.
Correct.
You be able to replicate this whole process, which is no longer you. It's about the system and the process and things like that. I think that is very valuable, and I think that selfless feel is what, because we say in spiritual about aham. It's about me versus, and you said so generously that it's about the society, and we are the way we are. And I think nothing was demonstrated better than during the COVID time.
Correct.
I still remember, those people during COVID time would come and call me, "Sir, I won't come to hospital. I'm afraid I'll get COVID." I said, "Boys, 95% COVID is happening outside the hospital. It's not happening inside the hospital."
Correct.
So, I mean, how people are in this whole, I don't know where they get all this unnecessary wrong, this WhatsApp university, as we say,
Correct.
It is quite frightening, like how you mentioned yourself, how your mother said that. So, but what is your vision, for this field of neurointervention, especially stroke care and things like that? Where do you think this will head? Before I actually ask that question, I have one more important question to ask you. I forgot. See, it sounds very exciting of what you do, but I know the risks that you are going through, especially the risk of exposure to radiation. Very few people know that. The amount of radiation exposure that you guys get in the cath lab is very high. So what do you guys do? How are you protecting yourself, and what more do you do? How do you measure all these things to make sure that you don't get impacted by that, and you and your staff?
So the present fluoroscopy machine, again, thanks to the technology, the fluoroscopy machine is very good.
Okay.
So we have lead production shields, everything. So the exposure to the patient and to the operator has reduced significantly.
I see.
For example, earlier when I was trained, if you do a long case, for example, dural fistula for 4-5 hours, some of the cases they used to lose hair temporarily.
Really?
Yeah. During my training.
Whoa.
Okay. So now hardly we see any hair loss. So the radiation, the technology, all those things have improved significantly. So the radiation to the operator and to the patient is very less.
Very less. But you wear some badge,
TLD badge and all. We do that auditing and everything, but it is never.
It's never over. And you don't also see, something like that.
Correct.
One more thing came to my mind as you were talking is yesterday you posted one more about some CCF.
Yeah.
CCB is chow bath, and this is what CCF in heart is, congestive cardiac failure. But what is this CCF and what happens? Because I have seen CCF many times in patients who have a head injury. So what is this case that you shared about? And
so CCF is a cardiac cavernous fistula. Like as I said, there are two types of blood vessels. There is abnormal connection between the artery and the vein behind the eye. So that is seen after the trauma, head injury. It can come immediately after a few weeks or months' time. So there will be sudden abnormal connection between the artery and vein. The pressure inside the vein goes up and the eye will pop out. And that will cause severe...
the eye pops out.
Correct. And there will be severe redness and they may lose vision. So in those conditions, what we do, there are various techniques again to seal the opening between the artery and the vein. So sometimes we use stent grafts, which is like a tube. It is usually from the cardiac system. So we go and block that. We put the tube across the rent so that the blood flows through the tube and the rent is sealed. And immediately, again, within 24 hours,
I see. I've seen.
completely.
It's magical. Sometimes I go in sometimes. But does the vision come back?
So if it is severe and traumatic visual loss and optic nerve is damaged completely, it will never come back. But if it is because of venous congestion, all those things, if we seal the fistula, and usually once the edema settles down, it can come back.
It can come back. So keratoconcaverous fistula is one more set of things that you handle in your toolkit or whatever you call it at the end of the day. I have one more story to tell you. This is a girl we had recently. She is about 18, 19 years probably. She's a boxer. She's training to be a boxing, professional. And she was in a boxing competition. And somebody, opposite person punched her and she fell down. And then they realized she was unconscious, for some time. So the bout was called off and she was rushed to hospital. And by the time she reached hospital, she had gained consciousness, but they found that she had a left-sided weakness, complete weakness. She was complaining of headache. And then they did a CT scan and they found a clot inside, what we call as over the surface of the brain, called an acute subdural hematoma. And then, somebody knew us, so they shifted her to us and we looked at the scan. Something was not okay on the scan because gut feeling, intuition, gut feeling, whatever you say. So we chased it with an angiogram, CT angiogram, and we found that she had a dural AV fistula. But then she was rapidly worsening. She suddenly became unconscious again and things like that. So we had to first evacuate the clot in the brain. And then we did the
Hemorrhage.
AVF.
Hemorrhage.
So you have, and she did very well. She now recovered nicely. So what is your take on this dural ABF, or what we call as AB fistula? So another new word now.
Yeah.
In the trauma, so many new words we're telling our, global viewers.
So main thing is we need to differentiate a fistula from the arteriovenous malformation. Fistula is the direct connection between artery and vein. Okay. So if you put a wire, it will go through the wire into the vein.
Okay.
So that is a fistula. Fistula, anywhere it can happen, from the head to toe. So arteriovenous malformation is there is a mesh of blood vessel which is abnormal in between the artery and vein.
Got it.
So like if you put a wire, it won't go into the wire. There is a mesh. So this is the difference. Dural arteriovenous fistula is a fistula which happens on the dura. Okay. So the presentation of dural fistula is varied.
Okay.
In some cases, it is missed for months or years.
Really?
Yeah. So it can present like a Parkinsonism.
What?
Yeah, I have a few cases where Parkinson's disease with fluctuation.
How is it really?
Yeah, it can present like a Parkinsonism.
Whoa.
And it can come with a dementia. I had a doctor who stopped practice because of the dementia. He had a dural fistula.
My goodness,
they can
crazy.
come with they can come with subdural hemorrhage. They can come with seizure, fits, epilepsy. I have a case last week we did. He came with seizure. So the presentation of the dural fistula is varied. Okay, because
this is frightening. Even as a neurosurgeon, sometimes you start thinking of, wow,
it can come with dementia, it can come with
goodness.
Parkinsonism, it can come with brain hemorrhage, it can come with paraparesis, it can come with proptosis, chemosis. So it is extensive and varied. It can come with raised ICP. So in India, post CVT, venous thrombosis, if the swelling inside the brain or eye is persistent after 6 months to 1 year, there may be a case of dural fistula. So the presentation is varied.
Varied.
And but good news is it is very challenging to treat, and it is beautifully we can treat and cure it. So these patients who had Parkinsonism, it recovered completely.
Oh.
The doctor who had dementia, he started practicing.
Amazing.
Yeah.
Amazing.
So this is one of the treatable condition.
Interesting. No, but do they get picked up on just a routine CT brain plane or a routine MRI brain, or you have to do some special scans for that?
Yeah. So I think in MR, the chances of picking abnormal flow voids, tortuous flow voids is high. But any atypical bleed, it is important to do angiogram, 6-vessel angiogram. Some people, they do 3-vessel and miss it. So it is important to do 6-vessel angiogram and do it properly. Then only we can pick up these cases.
Oh, so we didn't go deep into the radiology of even in stroke. So what you're saying is, just because you have your tool in your hand, it doesn't mean it'll give you the right result unless you ask the right question or ask for the right sequence. And that I think is very important for the
even sometimes the radiologists, they miss it because it is very uncommon. So they may not be trained into looking into that.
I think that's why people like you and me look at the scans ourselves more often than not, because we see so many of them. You can't blame anybody because they're not neuroradiologists.
It is rare.
It is rare, and that's what very important for us to. So eventually, what are you saying is there has to be a high level of clinical suspicion that there's something not standard. He's not following the script. So I need to chase it beyond, to make sure that I've at least ruled out even the rarer things and things like that, and we get that sorted out. So coming back to stroke, just on the radiology, because I think we didn't cover that. So I know so many situations that, like you said, people go to the local doctor, he asks for a CT scan. CT is normal, he says CT is normal, go back home. Or sometimes they do a routine MRI. Routine MRI also can be normal. So what is this all about? What do you mean, doc? The audience will ask you, you're saying CT scan you do, it's normal. MRI do, but you say it's not okay. What's going on in this space in acute stroke and radiology and imaging?
Yeah, so main thing is stroke is a clinical diagnosis.
Okay. Clinical means doctor has to see first and he has to understand.
And analyze the symptoms.
Got
so
it.
anything sudden focal deficit. In brain, there are two things which are sudden. One is trauma. Anyhow, there will be obvious history of trauma.
Correct.
If it is sudden focal neurological episode, suddenly, so it is stroke unless proved otherwise. So either you do the brain not to diagnose CT, we do not to diagnose stroke. It is to rule out a bleed. So same
Brain
way in
hemorrhage
MR.
is what we call brain hemorrhage.
Brain hemorrhage. So same thing even in the MRI. So it depends on the specific center whether they want to do CT or MRI. It depends on the center, the availability. We can use both. So both things we do. There are a specific sequence in MR which, for example, diffusion MR, which will pick up the stroke early. CT we may not find early stroke changes, but we do CT just to rule out a brain hemorrhage. So the main thing is sudden weakness, sudden giddiness, sudden dysarthria is brain stroke. We do imaging mainly to rule out a bleed, and we start the treatment.
Got it. Now, since you're at the symptoms again of sudden onset, what are all the, like you mentioned dementia, what are all the different kinds of symptoms patients are coming with vascular problems in their brain? Just to understand, like vision, it doesn't have to be a weakness of one side. I know about that.
Correct.
What all have you seen in your 20 years of practice?
Yeah, so sometimes
Funny, some of them are very interesting even for you. You said, whoa, I didn't realize this.
Yeah, so sometimes patient can come in sudden coma.
Okay.
That can be a symptom of brain stroke. Sometimes the patient will come with fever and brain coma. It can be missed like meningitis or encephalitis.
Okay.
And some people who have brain stroke on the right side, they may be weak on the left side, but they will not know that they are having weakness. So because of that neglect, I think.
Okay.
So those are the patient even for difficult for rehabilitation because they may think that their arm is someone else. I think so. This is a confusion, and as I said, some patient will start talking irrelevantly. They will talk nonsense. They will take to psychiatry hospital. Then they will realize that it is sudden onset. He did not have past history, and then they will bring to the hospital. So these are all varied symptoms. So again, but the basic, most 90% will be covered with that mnemonic be fast.
Be fast. So that at least covers that. So the last topic I want to talk about is CVT, or what you do in a condition called IIH or whatever it is.
Yeah.
So there are also all these you're talking so far, most of it was from the arterial side of you're trying to handle this whole thing, as what I understand. So from the venous side also, you said you sometimes do procedures. So what are the common venous procedures that you do, that you see, and can you educate our viewers?
Yeah, so venous strokes, for example, CVT, where the blood flow from the brain to the heart is blocked. If we identify, so the presentation is different. Usually it is peripartum after delivery. They come with severe headache, vomiting, and then they'll start developing weakness. If we identify early, we can give a heparin injection, and 95% of patients, they will be cured of it. So if they are worsening, or if they come in coma, or they come in recurrent fits, in those conditions, we go from venous side and we suck the clot out, or we remove the clot out. So these are all venous procedures. So same time, if there is a raised ICP because of
pressure inside the brain,
IIH, sometimes a patient can have venous blocks, venous blockage. So in those conditions, who are refractory to medical treatment and who have persistent eye swelling or raised pressure inside the brain, in those conditions we put a venous stent. And
are the stents different from arterial stents?
No, they're all same arterial stents only we use for venous stent. But now they have come up with a different venous stent. It is not available in India, but it is that doesn't matter.
Doesn't matter.
That is called venous stenting.
Got it. So just to educate the global viewers, that CVT, he said postpartum. Postpartum means after delivery. This is the very commonest thing that can happen immediately after delivery. The mother can get a fits, become unconscious, semi-conscious. So that's when some hormone imbalance, the change that happens causes brain hemorrhage. That's one thing. But we also see CVT is very commonly these women who take period postponing pills very commonly, or oral contraceptives. Okay. And it's not the number of tablets they take. Sometimes with one tablet, two tablets, we have seen devastating CVT. So you have to be very careful that you can't pop in like a vitamin tablet. People do it all the time. Some Puja Bantu, this came, that came, and things like that. That's another message we want to give. And this IH, I had a personal thing. Somebody known in my family in Canada, she developed this visual problem. She was having a lot of this visual flashing. They finally found out that her pressure inside the brain was more, her vision was coming down. They found that, transverse sinus was thing, and they went and did the procedure, and she's gotten better from that.
So also one more thing which we forgot is the pediatric neurointervention. Okay.
Correct.
So
thanks for bringing that up.
We do neonatal day one child procedures for vein of Galen.
That's
last
right.
week I did vein of Galen malformation embolization.
How did I forget that?
Yeah. So
Thanks
that also
for
we
bringing
do it.
Fantastic.
Usually
One day child, huh?
Yeah, day one child, day 3 child, 5 months child. So we do pediatric intervention. So it is again technically challenging.
I agree.
Getting access and the contrast load, everything, and fragile arteries. So we do embolization for that. We do embolization for AVMs of the brain and spinal cord, and also retinoblastoma. So,
what do you do for retinoblastoma?
Yeah, so if the retinoblastoma in some stage, we go inside the ophthalmic artery and give chemotherapy. So intraarterial chemotherapy we do for pediatric.
That also comes to you.
Yeah, so we do.
Does it help? Does it really help?
Yeah, significantly there will be shrinkage of the
It's now standard of care, huh?
Yeah, it is
Oh,
standard.
I had not heard of this.
So the interventions are varied. It can spinal cord to the brain, from pediatric day one child to 100 years. So the spectrum is wide.
Huge.
So you can do embolization, AVM, dural fistula embolization, spinal cord embolization, and even if there is a hemangioma in the vertebral body, we do embolization. String. So the various interventions. So it is a huge field now, and sometimes for chronic subdural hemorrhage, we do MMA embolization.
That's right. I was just going to ask you that question. You brought it up. That's become like a new fashion right now. Yes. In fact, I took it on to it only about a year and a half back. I was very hesitant in that in the beginning.
Yes,
but we had, what are your results with that? I mean, I've done very few. We have got it done.
Yeah. So again, because we are a big cardiac...
Chronic subdural, just let me tell the viewers about chronic subdural hematoma is a clot which is outside the brain, inside the skull, which is not happened yesterday. It happens over a period of a few weeks to a few months, very commonly seen in elderly people. And many of them don't even remember getting hit on the head. Yeah. Some small edge of the window or something like that. And this is more common in elderly people for two reasons. Number one, their brain shrinks, so there's a bigger gap between the brain and the skull. So small bridging veins, small veins sometimes can snap and slowly it starts bleeding. More commonly, most of them have some heart problem or some leg vessel problem because they're on blood thinners. So that blood thinners again causes this problem. So either way, whatever the cause is, so if you have this problem and they're too old to operate or they're completely all right, not too many problems, then I think that's when the middle meningeal artery embolization comes in. So what do you do? What's your
So middle meningeal artery is a simple procedure. It is simplest procedure than even cerebral angiogram.
Really?
Yeah. So when we started initially, no one believed it. Actually, it works.
Because, I also didn't believe it. Let me be honest.
Because the philosophy is chronic subdural is venous leakage.
Correct. Exactly.
So now 3 trials have come, which is strongly positive. So it is because of the cycle of hypervascularity, which causes ooze and chronic subdural hemorrhage. So if there is a significant midline shift, we need to do surgery. It means you remove the... so that around 11 to 12% there will be recurrence. Okay, so we want to prevent the recurrence. So what is you do the surgery and then we do the middle meningeal artery embolization. It's simple procedure. Go into the middle meningeal artery and do embolic, block it. Okay, using the PVA or glue or onyx. There are many things. So once we block it, that vascularity is stopped and the cycle is broken, and that's how it shrinks. So it will be helpful in those patients who had recurrence. Or post now thing is you do the surgery and do this post surgery for all patients. Prevent, or if some patients require anticoagulation or antiplatelet because they have cardiac problem.
And you can't stop it.
So on those situations we can do it and results are beautiful.
Very good. I think
simple procedure.
Perfect. I think viewers, as you can see, there's so much going on in this field of neurointervention. You don't have to get overwhelmed by what Dr. Vikram has really given a download of that. All you have to understand is, like he said in the beginning, there is hope.
intervention.
There's so many things that we can do, so many different ways to skin a cat, and you have to go to the right place at the right time, get the right diagnosis, the right strategies done, and if done well, obviously, like you said, the results can be magical. There's somebody above us who eventually determines what is going to happen, not going to happen. That is destiny, fate, God, whatever you call it. There are different things that you can do, and I think we get more spiritual as we start seeing more of these things and understand that we are not in control of what we do, and eventually we do what we can do best at the end of the day. And yes, you want to say something?
But good thing is now neuroscience field has evolved significantly. The various treatments available for various conditions.
Correct.
I'm not talking about stroke.
Correct.
Various conditions there is treatment available.
Correct.
Maybe epilepsy, movement disorder, neuromuscular problem, immunotherapies.
True.
So neuroscience, when I started 30 years back, it was just B12 and steroids. Correct?
Yeah, really.
So it was only two things. And from there to now, after 30 years, you can see it is
Tremendous.
mind-blowing. And I think in future also, it will be more treatment techniques will come in neuroscience. It's an amazing thing.
I agree. I think what happened with neuroscience was the neglected child, because the rest of them were being sorted out.
Correct.
I think the rest of the organs seems to be sorted out more or less. I think that's why they find that this is more place to do that.
So even in cricket, they got helmet after some time.
Yes.
So now they thought that brain is also important.
That is right. I was wondering why you said that. They were protecting other things than the brain.
So again,
Very
brain is
true.
important, and we are there because of the brain.
I
And we
agree.
can't do
I
transplant.
agree.
We
I
need to
agree.
save the brain.
I agree.
And I think preventive checkup is more important.
So one more story I saw you had posted, I think it came all over the news. You said somebody had 100 strokes or more than that. Or so. 100? I mean, we get scared with one stroke, you will die, you will survive, disability. How is this guy walking around with 100 strokes? What's going on here?
So there is minor strokes. So or TIA. TIA is some people will have a transient weakness on one side of the body, and they will improve in 5 minutes to 1 hour time.
Oh, okay.
So this person had a hemodynamic stroke, means he had a focal cerebral arteriopathy, which is an inflamed condition inside the brain, which causes narrowing. Okay.
Oh, okay.
So that was producing his hemodynamic stroke. So whenever he used to stand, he used to.
It's not a clot going up, but just going up and down.
So that was a blockage where blood flow is not restored. When he stands, he develops weakness. So the TIA usually will happen only in 25% of people. Otherwise, it is full-blown stroke. So that's why it is important to recognize these TIAs.
Correct.
And
I agree.
we need to evaluate.
I agree.
And this person used to have recurrent TIA or minor strokes. So he used to have every day around 10 times. Means if he stands, he develop weakness, and he used to lie. He can't do anything.
Crazy. And he didn't do anything about it for initially.
No, he didn't do anything. He went to the hospital, they treated, they gave blood thinner, they gave steroid, everything, but he is not responding. So that time again, you need to think. What we can do, what innovations you can do.
Correct.
And in him, we used a balloon because it is inflamed. If you give a bigger balloon, it can rupture. So we did not wanted to put a stent. Again, same thing. It can rupture. So initially we used a balloon, and again he improved completely. And after 3 days, again he started developing because it is inflamed condition and it has collapsed. Yeah.
Correct.
So in that again we used a drug-eluting balloon of the heart. So drug-eluting balloon is where in the balloon they are coated with a drug which gets it will diffuse into the artery. Okay, so we used that, and on that we used a self-expandable stent, which is a neurostent. So the problem with neurostents, which is used for atherosclerosis, is they are not coated because it has to be flexible. They don't coat, and they can block again around 30%. And here is a young person who is inflamed artery. On that you have put a self-expandable stent. So most of the stents will get occluded. So we use this technique of drug-eluting balloon, and then we have deployed it. Until date, touch wood, more than 1 year, he is without any TIA. I think so. This was a new breakthrough, which it is possible. Now we are using this drug-dilating balloon commonly.
More regularly. This helps you to do that.
Yeah.
Like we say, the cat has 9 lives. This fellow was so lucky. I think I tell some patients like this, go and do pranam in front of God, because it's too much, for him to have survived all of this. And he's all right walking around, going back to work. Amazing. So this is incredible stories. We're going to take a deep breath now. So much is happening, so much excitement, and so much of innovation, and so much of benefit for families and the patients. I think they should really benefit from this. So I think, again, like I said, thank you very much for what you have done for the society. We want thousands of Vikram Hudeds, around the country and beyond. I think you're doing human service, and we'll really look forward to, interactions at different spaces and see how we can help taking that forward for sure. So you have any last words to say?
Yeah, I thank you for this initiative. I enjoyed the process, and it is important to do such activities. I think Rebooting the Brain is a very good initiative, and such videos will bring awareness among the public, and I really thank you and your team for giving me this opportunity.
It's our pleasure. So viewers, as you can see, that this is just the beginning of an amazing roller coaster journey. Don't expect all hunky-dory things from us, because we are going to talk reality. And reality is always like this, goes ups and downs. All results are not great, as Vikram has said, and we know from our practice. So that's what it is. So don't forget to be tuned in, because we are looking at doing lots more videos like this on different topics. We have a fantastic line of speakers already lined up, and more to go. So subscribe, like the channel, click the icon, bell icon, and share this video widely so more and more people can benefit. They can go to wherever the closest doctor is, the closest Vikram Huded is in their world, to find somebody who can make this difference. Thank you very much, Vikram. Thank you very much. Okay, Vikram, the book from our sides. Thank you so much for coming, and look forward to your feedback on the book.
Definitely.